A warm welcome to this talk and welcome back Dr. Clare Craig. Clare, thank you so much for coming back on.
Thanks for having me, John. Nice to see you.
You too, always. Now, there's been a sort of a quiet revolution in my view over the past few weeks in the United Kingdom. And I think it's important that we look at it because we really need to learn from the past or make the mistakes again. It's well rehearsed. But there's been a major change in the whole philosophical predisposition and practical predisposition of the United Kingdom, in my view. And it's almost gone below the radar. Most people aren't really aware of it. And this is the assisted dying measures that have come through in the UK Parliament. And before we get down to some of the excellent points you've made, teaching us how to learn from the mistakes of COVID to attribute this to the assisted dying, my first thought of this really was, if it ain't bust, don't fix it, because you've been a clinician, you've been you're a consultant trained pathologist, and I've sadly been there many times when people have left us, left this life. And if people have pain, we have really good strategies to treat that. If people have distress, we have good strategies to treat that. Now, very often, sadly, it's not done as well as it could be. But,
yeah,
if someone's in pain, we double the dose and we double the dose.
That's right. And there's something about this. It feels like there are things that you get taught when you're in medical school. There are things that you learn when you're a doctor. And doctors generally understand those things, and nurses too, So we understand how death is managed to a certain degree. Obviously, we're specialists who understand it better. But, we have a broad feeling on that. We also get taught medical ethics. And, we've seen over the last 2 years politicians playing doctors and nurses. That's what's happened. Politicians and bureaucrats have had this massive game of doctors and nurses. And now they're doing it again. And again, they're not stopping and thinking, well, if I'd been at medical school, maybe I would have been taught medical ethics. And what would that have told me about this topic? They're just wading in there thinking they know best. And it's disastrous.
Mm-hmm, yeah, I agree. Well, there's so many arguments, but let's go through the points you've made, really to learn from the COVID debacle and the drastic mistakes that, in retrospect, now are so clear that were made by our leaders and betters, or supposed betters. The first one is lockdowns crossed the Rubicon in terms of civil rights, overturning the social contract. So the analogy here is Julius Caesar crossing the river to go into Rome with his soldiers. And it's something that's really quite hard to reverse once it's done, isn't it? It's a really apt analogy. And euthanasia crosses a Rubicon in terms of moral norms. So maybe tell us about the COVID one first. How was the Rubicon crossed there? And then how has the Rubicon been crossed in the assisted dying legislation that's in train?
So we had a sort of idea that there were civil liberties and that our democracies were based upon them. And those included a right to go to work and a right to move and a right to see people when they're dying and a right to have weddings and, all sorts of basic aspects of how a society functions that were just ignored and trodden upon. And, that the fact, and the scariest thing, of course, is that people haven't acknowledged that and haven't talked about that. And so, what happens once you've had something, had policies that have overridden those, is that they can always be overridden again. They no longer exist. We no longer have that basic agreement that you allow people to go to work, you allow them to travel. We don't have it anymore because it's been removed. Yeah. And so that's the problem. The problem is that if we want to return to a society that respects civil rights, then we have to acknowledge the civil rights have been trampled on and start again, because you can't just sort of sidle back to before. It doesn't work like that.
Yeah, the precedents have been set and we need truth and reconciliation to bring that out.
Mm-hmm. And then, of course, for the assisted dying, we've had moral norms that are based on the 10 Commandments fundamentally. And this one is just, trampling over the major do not kill. And do not kill is not just a basis of any particular religion. It's a basis of all civil societies. Yeah. It's the most basic principle about how people live with each other, is that they don't kill each other. And this assisted dying or assisted suicide, which is what it is, you're trying to get other people involved in someone's suicide, because actually at the moment, suicide is not illegal and it's not punished. And, so people actually do have that choice open to them. But what you're trying to do is get the medical profession involved in somebody's suicide. And that makes them culpable for someone else's death. And that's a wrong thing to do. It's wrong.
Yeah, the sixth commandment in Judeo-Christian tradition, and as you say, every single tradition in the world, every ethical tradition in the world, human life is sacrosanct. It's why we do what we do, really, isn't it? It's quite a concern. Now, the other thing you pointed out is the divide on this, and Parliament did vote in favour of this by quite a large majority, but it crossed traditional party lines.
It did. I mean, it's worth pointing out this was a second reading. It's not over yet.
Okay, no.
Yeah, but it absolutely did cross party lines. So the Liberal Democrats were almost all for it, but and the Green Party were all for it. But otherwise, this is not something that's party political. There's something deeper about it. And so the traditional socialists like Jeremy Corbyn and Diane Abbott, they were strongly opposed. And, so it's the progressive left that seemed to be strongly for. And obviously there is also a progressive right that seemed to be for. But anybody that has any kind of grounding in anything that we used to call normal are against. And the arguments that are being put forward for it are really emotive, and they are not things that I am dismissing. Right? They're the stories people tell around people suffering when they're dying. I think they're exaggerated. I think people have an exaggerated fear of pain when they're dying, and an exaggerated fear of loss of dignity when they're dying. And most of it, as you said at the beginning, can be managed really well. But there are exceptions. There are. And I acknowledge that there are. And I think whenever you've got these difficult situations, you need to be balancing up what you are doing to solve a problem for a small group, and what the consequences are of doing that. Because it's not black and white, it's grey. But once you look into the grey, it's clear that the things have got out of proportion in people's thinking.
But I agree with that. But if things are well managed, I was talking to some colleagues in hospice care, and actually the majority of their patients now in hospice care die with syringe drivers, which means they get a constant infusion of drugs, and the level of consciousness and high levels of analgesia in their system can be really pretty high for the hours before death. So, the consensus from the hospice people seems to be that they can manage symptoms as long as they have the resources to do it. But I agree that there is the odd one.
We don't fund hospice care.
Exactly.
It's awful. I mean, it's charitably funded. Only 30% of hospice care comes from the government. Yeah. And when they were discussing this bill in Parliament, there was actually another bill that was due to be discussed on funding children's hospice care, which got bumped down the road so that they could talk about killing people. This is just insane.
Yeah. Yep, it's we are very good at doing these things if we do them properly. Absolutely. Now, in COVID, especially with with all aspects of COVID, we could think of the vaccines, we could think of the lockdowns, we could think of all sorts of things in COVID. But the risk-benefit analysis wasn't done prospectively, in my view. It was kind of at best done on the trot, and at worst not done at all. And I think it's much the same with this. The risk-benefit analysis hasn't really been calculated. So you've pointed out that there is a potential benefit for a very small number of patients, and I think we can accept that. But it is a very small number, especially when hospice care's not there. But what are the risks here, Claire?
So the risks I think are huge, and the risks are to setting up a situation where, first of all, doctors might kill you right now. So we've already got a difficult relationship between doctors and patients since the COVID issue, and trust has been damaged. And you do not restore trust by giving doctors a license to kill. That's really not a great way of restoring trust at all, right? So there's that fundamental relationship that is going to be destroyed. And then you've got the sort of attitude towards the state. What is it that the state should be striving for? Is it meant to be striving for a better life for people, or are they striving to end people's lives? That's a fundamental risk. And then, a lot of people have been talking very, very eloquently about the risks to the vulnerable and to the disabled. And there are 350 disabled charities. All of them are opposed to this, right? There isn't one that's for it. They're all opposed to it because they can see what's happened in other countries. And it really is the slipperiest of slippery slopes. It's horrific what happens. And disabled people seem to end up being pressured into having this, well, not necessarily having it, but it's talked about, it's introduced completely inappropriately. And if you're a disabled and perhaps you're having a period of being mentally vulnerable, and then this gets introduced.
As we all do.
Absolutely. And the thing is, we're going to have this dual system where if you're physically healthy and mentally vulnerable, people will put things in place to protect you from suicide. And if you are potentially not physically healthy and mentally vulnerable, they're going to start doing the opposite. So just because of your physical health, you're going to be treated differently for a mental problem, which is terrifying for disabled people. They've become a sort of second-class citizen in that regard.
Yeah, there is a lot of genuine fear around, for sure. And not only that, my concern is it'll be done on grounds of intelligence, willingness to argue. I mean, we already know that the eloquent middle class can get much more out of health services than the people who are perhaps less able to articulate their needs. And the idea that whether you live or die or not should depend on how clever you are or articulate you are, or even worse, how wealthy you are.
The wealthy thing is important. So in Canada, where they really travelled down this slippery slope since they've introduced it, there are genuine stories of people who have opted for this because they couldn't afford pain relief, or have been offered it because they're homeless. And actually, the surveying the public. The sort of public seem to agree that these are genuinely, those kinds of reasons are okay and acceptable for this. And you're like, well, that's awful. That's really awful. Our whole society is going to fall apart if we start saying that there are worthier and less worthy lives to live.
Yeah. An underclass. In fact, we could translate that into another language. I don't know, make one up. Maybe German, Übermensch. There's alarming parallels here with the past. Lack of input from ethical advisors. I mean, as far as you know, has there been ethical advisors involved in this legislation so far? I haven't heard of anything.
So what I've sort of figured out is that the government doesn't really have ethical advisors.
Right. Yes.
So they have it for a few niche things. So there's one for the use of AI in the military. They've got an ethics board for that.
Right.
This is like ethics boards for sort of little niche things, and they set one up for COVID, which they then didn't use when they're talking about the vaccines, but that's been disbanded. I'm not sure that they necessarily had an obvious, board to go to, but obviously there's plenty of medical ethicists that they could have asked for help. You don't have to have your own advisors. There are people, there are experts, there are groups they could have sought help from. And in terms of that risk-benefit calculation, just popping back to that for COVID. They didn't do it at the beginning. And they did do it over the summer in 2020. And reading what they said is just, it's completely detached from reality. Yeah. So they didn't seem to take any lessons from what had actually happened in spring. And they made claims like people would drink less alcohol, so there'd be less liver disease. And exactly. And that there'd be fewer deaths from dementia. Like, this is completely... they have evidence that both of those things, the opposite was true. Yeah. And so then they do a calculation about how lockdown saves lives because of, all of these, how we all live so happily when we're locked down.
But based on hypothetical mathematical modelling very often.
But on assumptions plucked out the air.
Yes, exactly. You plug in, whatever you plug into the model determines what you get out of the model.
Yeah.
The vaccine saved millions of lives. Everyone knows that. If you use the right model with the right ludicrous assumptions. If you want to believe that,
So I suppose having said that, you'd think, well, what's the point of them doing a risk-benefit calculation on this if it's going to be so ridiculous? And there is some truth in that. But I think what you want is politicians to go slowly enough that the risks are considered. It doesn't feel like that's happened.
That was the other thing with COVID. Things were introduced rapidly. Basically, an announcement from the Prime Minister, that's it. And in the same here, it seems to be with this new government, it's a very rapid change in these fundamental principles.
Right.
Our society has been based on since Magna Carta and before.
Right. And you'd think that such a fundamental change would come with a lot of public debate.
Yeah.
You'd want to have, a lot of conversations in the media, and why not take years overdoing it, or at least a year overdoing it? And it's not happening like that at all. It's being done on the sly almost. I mean, it is obviously in the open, and there have been some reports in the press. But as you said, most people are completely oblivious to it. And I think is a really important point is that there was a survey. There's like lots of surveys get done by the pro assisted dying groups. And they make the claim that 80% of people support this at any age, in fact, slightly higher for slightly older people. And when you have surveys that actually educate people a little bit before asking the questions, so, just give them a bit of information about what it actually entails, that drops to 11%. Now, actually, I find that hugely encouraging, because if that's true for the public, I'm sure it's also true for politicians.
If people are actually given the information to make objective ethical decisions, they're still capable of making objective ethical decisions.
Now, of course, if we had a public debate, then that means that would happen, and that means that support would fall to 11%. So you could see why the pro-bill people wouldn't want that to happen.
Yeah. So the media campaigning that's going on is mostly for the pro-assisted dying group. I think That is that fair to say, do you think? Yeah,
well, the thing is they've got massive funding. The people who are opposed to this they just don't have money to be plastering, the tube station at Westminster with posters and...
Oh, I haven't seen that, is there?
Oh, that was something else. So
I haven't seen that.
There's a tunnel that goes from the Westminster Underground to the sort of other side of the road so that you come out by the Houses of Parliament.
Yeah.
Every bit of this tunnel had posters from Dignity in Dying, which were sort of glorifying it. They have a young woman looking joyful and, in fact, ecstatic, jumping in pink pajamas in her kitchen about how she wants to stop her. She doesn't. She's dying and she doesn't want her family to suffer. And whoopee, let's all kill me. I mean, it was really bizarre, like really, completely horrible. And of course, most train stations have the opposite. They have suicide warning posters.
Yes.
Here's how you can get help. And so some resourceful people went out and got Samaritan posters and stuck them over these ones, and then they were removed and they were put back again. But this is what the politicians are seeing every single day on the way to work, because of course that's all you need to target if you're for this bill. You just throw your money at brainwashing the politicians.
Yeah, it's a bit of a diversion, but I wonder if the advertising space in that tunnel on the way to Parliament is sold at a premium. I don't know that one.
Yeah,
it's an interesting question. So we had this idea in COVID that we could control the virus, that human beings have, I don't know, what's the word, supremacy. And the idea that we can control a respiratory virus, as you've so brilliantly pointed out in your books, is just, it's fantasy. And likewise, we have this fantasy of control, that we have some control over our deaths. Again, we're kind of into the world of fantasy here. We don't have control over these things.
No, and we can't predict the future. That's the other big one.
No.
So, the whole of the COVID story was around scientists doing their modelling and saying what was going to happen, again based on assumptions plucked out the air, like we were all susceptible to every variant. And so they came up with crazy predictions. And here we've got the same sort of belief in the sort of high priest status of experts that doctors can predict when people are going to die. And we're not good at that. And we admit that we're not good at that. And yet they're sort of assuming that that's a black and white thing and that we can predict, 6 months, not 7 months, and therefore you're eligible. It's a nonsense.
Yeah.
Any doctor would tell you that's a nonsense. We can do it to a degree. You can kind of hint at things, but we get it wrong.
In some cases, some cases much clearer than others, of course. But human beings have this need to be in control, and we just have to admit the fact that we're not in control, actually, about most of the important things in life. We're actually not in control, but this is some fantasy that we seem to pursuing. Now, the reality of the process is perhaps not what people expect. And again, this applies to both, doesn't it? The reality of the process of lockdowns and vaccinations, and the reality of the process of actually ending someone's life. So, and you mentioned Oregon here. What was the issue with that, Claire?
So Oregon published their data on the sort of efficacy, if you like,
Yes.
what they're trying to do, and they were looking at different drugs that they were trying. But ultimately, the result is that the amount of time it takes to kill somebody varies enormously.
Yeah.
It was on average, many hours, but in some cases it's many days. And I think that's the kind of information that causes people to drop their support to 11%. Because, people who might momentarily feel like they've given up and want to end it, to sustain that thought constantly for days, not something that happens. And we all know that doesn't happen, because actually there are moments, even in the darkest pit, of wanting, of hope, of wanting more, of wanting to be with your loved ones, of wanting to have a laugh. All of that still is there. It still exists.
Of course, we saw the appalling situation in the United States, not that I'm picking on that, but certain states, with killing people via intravenous injections, where it was completely bungled. You ended up with people who had muscle relaxants and were awake. It's just an appalling situation that someone could be paralyzed and not able to move. This is a risk that anaesthetists are very aware of course, a terrifying possibility, and there is a very occasional cases of anaesthetic awareness.
But I think it's almost as if people have watched so many murder mysteries that this kind of fantasy of you poison someone and they drop dead is true in their minds. They think that that's a reality, that there are these poisons that you can take and that ends your life just like that, cleanly. And it is a fantasy.
The whole physiology of the body is trying to keep you alive, isn't it? That is absolutely the whole point. So lockdowns were predicated on a belief of the high priest status of doctors. So, the chief medical officer and the chief scientific officer came on TV there. So it must be right. We have this high priestly idea. What did you mean by that, Claire?
So I think we have this sort of concept around experts being infallible. So, I've got nothing against people having expertise, and I've got nothing against them sharing that expertise. But I have a big issue with not being able to question and challenge what they are saying, especially when the implications are so great, because actually nobody's omniscient, right? Nobody's omniscient, and experts inevitably have a distorted view of the world. We all do. We all each have a distorted view of the world. And so the way in a democracy that we handle that problem is that we give feedback, and that feedback, might be wrong. And when it is wrong, that enables people to communicate better and to make their arguments more clearly, or to just at least stop them from becoming high priests that can't be challenged. So even if the challenges are wrong, it's important that we can do that. But when the challenges are right, it corrects for mistakes, and it's what stops us going down dangerously wrong paths.
Yeah, the freedom for debate absolutely has to be there. And we haven't really covered this yet, but basically, people have always said that someone takes their own life when the balance of their mind is disturbed. And as you've said, depression is a real illness. I've worked with people who are depressed, and for them, they deserve to be depressed. There is no hope for them. Yes, other people might get better with antidepressants, but they won't. They will never recover. This is utterly hopeless. They're just a drain on other people. They're of no possible use. There's no possibility they'll ever get better, and they might as well end it all now. Now, that's what depression is. It's a state of hopelessness. And for those people, this is, of course, all those things I said were completely wrong objectively.
Yes.
People can get better. We have treated depression numerous. I've had periods of depression. I'm sure virtually everyone watching has. And when you're in it, you can't see a way out of it. But there is.
Yes.
And, you work with people who are depressed, and they'll say, I'm so pleased that you came alongside me then when I couldn't help myself. You helped me.
Right.
It's wonderful when people come back when they're out of the depression and say, look, John, I wasn't, I couldn't do anything then, but you told me and it was right. And, the idea that we would take this transient disturbance of mind as an absolute terminal decision rather than treating the depression is it goes against everything we've ever learnt in psychiatry, really.
Absolutely. And there's one interesting aspect of this whole story, which is that Keir Starmer says that he's doing this because of a promise he made to Esther Rantzen. And Esther Rantzen is terminally ill and is a member of Dignitas and was objecting to the fact that should she use to go and kill herself in Switzerland, her family couldn't be with her as she did it because they would be guilty of assisted suicide. Anyway, Esther Rantzen's interesting on this because she's stayed alive a lot longer than her doctor predicted, first of all.
Yeah, she's still with us, yeah.
Yeah, and there are these occasional headlines where she clearly is really appreciating life. So there was some headline about, I saw my tulips bloom, and when I planted them, I never thought I would get to see the day. And she's saying, I never thought I'd get to see the day when this legislation would be debated in Parliament. It's like, well, it's almost as if you're grateful for that, isn't it, Esther?
Yeah.
And why is it that you think, she's obviously chosen not to kill herself, being terminally ill.
But she's seen a tulip bloom, which is a wonderful thing.
Yeah, and you're like, well, why are you extrapolating from your fear of death to saying, everyone should be in changing society? I mean, come on, this is a very selfish approach to take.
People fear death, therefore they seek control over it. It's an anxiety-driven phenomenon.
Absolutely, and that fear of death obviously is also fundamental to what happened with COVID. Really, is fundamental. Yes. And I think ultimately we're in a society that's quite protected from death. Don't talk about it very much, and we don't
or see it. I didn't see a dead body till I was 18 and I was a student psychiatric nurse.
I think and I think that's actually really a really big point. So obviously you and I have done. And I think it was on the occasions when I've seen people die, I think I have increased in maturity a great deal because it puts things in perspective in a way that it's almost hard to explain to people. Obviously it's obvious in a superficial way that it would, but there's something spiritual about it as well as being just a physical thing, isn't there? And I think the fact that we've sort of sanitized it and taken it out is not good for people, actually. I think it leaves people with a sort of gap that needs filling.
If we forget that people are bio, psycho, social, spiritual beings, if we lose any of those components, in my view, we dehumanize ourselves. But in the past, the concept of the wake, the body would be there and people would say the final goodbyes. That's death's all hidden away now. It's all hush hush and
it is
not to be discussed in polite company.
It is, and there is almost a thing where our expectation is that at some point we'll die, and we will either we might want to be at home. Most people want to be at home, but it's likely that we won't be, and then that we'll be just taken away. And then the funeral directors, who are brilliant at what they do, but they are also trying to help with keeping it separate, and because it helps. I think they think it helps people manage their emotions to be able to offer to sort of keep people away, and obviously when that's on offer, it's easy to say yes, please, because actually, to be honest, I think if you were to say today, we would like to have some time with the body.
Yes.
You almost have people jumping down your throat saying that was wrong and that it was dangerous and that you weren't to do it. And so you've got to battle that as well if you want to just go back to how things used to be, because people suggest it's a public health risk. Which
in practice, I always went out of my way to facilitate that. So we would put the body in the room, we'd tuck the covers up, we'd do the hair, we'd put the teeth in, would always have one hand under the covers and one hand out of the covers so they could hold the patient's hand. And it was very beautiful in many situations. And people come back and say, after that again, they'll say, I so appreciated that time with the body, whether it's a few minutes or if they want to sit for hours, fine, let them.
Yeah, but I suppose
people really appreciated that.
That tends to happen only with the most immediate relatives. That's the thing,
Yes.
isn't it?
Yes.
And obviously it is a sensitive family moment,
Yeah.
and there should be that protection
Yeah,
of those immediate relatives.
Yeah.
But because it doesn't happen the way it used to with a broader circle,
Yeah.
people don't experience that until, say, their own parents are dying, or or there's some other tragedy in their life. But a lot of us can get to quite an age without experiencing that.
Indeed. And recognising the grieving process, inevitably there's going to be a grieving process. And it starts at that time saying goodbye to the body. It's and I've done this in family situations. I'm not going to go into it because I probably would get a bit emotional, but I'm sure we all have. Now, the other point that's not been talked about really is NHS resources. We're going to have to set up these facilities. We're going to have to train up nurses and doctors. We're going to have to put in NHS funds. I mean, the idea that this is part of the NHS to me is a bit very frightening. So we'd have a room where people are treated there, and then you would do that. You'd maybe wash your hands, and then you go to the room where people are given this alternative treatment. Maybe next door in the health service. We have a living room and a dying room. And so the NHS resources and the fact that would be potentially normalised as a part of health care.
Right.
It's just a massive contradictions.
It really is. And if you take a step back, you think, oh, I'm sorry, why do you want healthcare professionals involved in this at all?
Yes.
You just get executioners to give poison. You don't need doctors doing it. You don't need nurses involved.
It's a very good point.
Yeah. So why on earth are they doing it? And it's literally, I feel like it's literally because it's a pill, that they sort of, or they might be a pill, might not be a pill, but the fact that it's sort of something going into the body, they think, well, that's healthcare. Like, well, I'm sorry, I don't think it should have anything to do with healthcare at all. I'm just astonished that doctors are, obviously there are a lot of doctors objecting to this, but we need to be loud, we need to be really loud saying this is outrageous, this is not what we're for, this is not what we do.
Yeah, absolutely. I've never thought of that idea before. So we had some executioners. What was it? Was it Mr. Pierpoint or something? He was remarkably good at hanging people. It's not nice, but he became remarkably skilled at it, and was used after the Nuremberg trials, for example, and became remarkably skilled.
Yeah, isn't it?
Yeah. Anyway, moving on. Emotional stories. So, the emotional. Let's think of an emotional story from COVID. Take this vaccine, little boy, little girl. Otherwise, you're going to kill your granny. And you do love granny, don't you? It's just outrageous manipulation. And I think we got the same. MPs, a lot of them are career politicians. It seems one heck of a lot of them are lawyers. And I actually don't know of that many. I know of one nurse in Parliament, and I can only think of 2 doctors, I think, but I'm sure there's a few more. But basically, these are from a subset of society that, in my view, is not representative of society. We talk about having proportional representation of various ethnicities and things in Parliament, and good justification for that potentially. But why don't we say, well, look, there's 350,000 nurses in the country, therefore we should have at least 5 MPs who are nurses. Well, why don't we do that? But we don't. We should have at least 1 pharmacist. We should have 5 doctors, but we don't do this. And
I think it's all right. They're lawmakers, so to be trained in law is not awful. But the thing is that they need to be aware that they have that bias. That's the problem, is that they're not seeking out information from people who understand it. That's their job. They're meant to do that. And one of the things that has bothered me about the opposition to this is that a lot of people opposing it are also legally minded. And they're making arguments around process and around, the kind of wording of it, not around the fundamental principles. And as soon as you start arguing that the process hasn't been done properly, you're essentially arguing for it. Yep. And they don't seem to realise this. They've got to sort of say, no, I don't care what the process is. This is wrong. This is fundamentally wrong, and it will cause immense harm. And I think that argument just isn't being made clearly. And, you're right, it's because doctors and nurses aren't being heard. That is fundamentally the problem. But those lawmakers have a duty to seek out those voices.
Yeah, there's a fundamental axiom here, and if you argue about the process, basically you've accepted that it's okay to assist in this process. And of course, a patient's told to take some medication, and they're going, ooh, I can't quite get it to my mouth. And then maybe the doctor or the nurse's hand comes and helps them. And then it's a small step for the nurse or the doctor just to put it into their mouth. And then, the gradations of the slippery slope here are just so patently obvious and really frightening. Or the patient one day is got a low state of consciousness, or is too depressed. Someone in a depressive stupor can't do anything. And so, acting in their best interest, the doctor comes along and helps them with this process. And then that becomes normalised, and then the next thing, the slippery slope argument here is so strong. It's really quite frightening.
Yeah, I mean, one stunning statistic for me is that year in Canada, first of all, 4% of deaths were medically assisted. Crazy number. And 470 people were killed who weren't dying. That's what happened to the slippery slope. It just expands and expands and expands. And in Oregon, they've been killing people who have anorexia or for their arthritis. And, there is no end to it. And people have pointed out that the arguments being made in Parliament for introducing this, none of those arguments would be different for children. So they haven't actually got an argument for doing this that would exclude children, which means that's, the slippery slope will head in that direction.
I don't want to get into it now, but the parallels with the 1967 Abortion Act are clear to me as well. Initially, lots of safeguards, procedures were followed. But, by 1968, the number of abortions had gone up really quite dramatically. And I think we could predict with a high level of confidence that if this was instigated into English law, the number of assisted suicides would dramatically increase in a very short period of time.
I think that's a completely fair assumption to make. And I don't think anyone's really denying it. In fact, Kim Ledbetter, whose bill it is, has, in one interview, she was sort of saying, well, that's what we're proposing for the moment. You're like, well, yeah, because we all know that this is beginning a journey in a particular direction.
Yeah.
And you have to stop it at its root.
Yeah.
You have to.
Because once the assisted suicide is normalised, and that's normal, we accept that as normal, then the doctor-assisted dying is just one small step away, and then people being got rid of for reasons that they might be a little bit inconvenient. It's all again. We're not going to go into it, but we've seen this in regimes in the past. It starts off with a particular group of people, and in the past it's ended up with whole races of people.
Absolutely, and it's not difficult, I find, to get people of a certain age to say, I don't want to be a burden. It's really not difficult to get
it all the time.
Yeah. And
I'm sorry to be a nuisance, lad. I get that all the time.
Yeah. And here we are with Kim Ledbetter again saying, she has said that she thinks feeling like that is a justifiable reason to get killed. Yeah. Like, well, that's awful. We can't do that to people. People... No. That our society has dependence, which is fine. It's fine.
Absolutely, it is. Yeah.
All of us are dependent at different stages of our lives.
Yeah.
That's just the nature of living in a society. Yeah. It's just the nature of being human, right? That's a human thing, that we have periods of looking after dependence and we have periods of being dependent.
Yeah. You're not a nuisance. I am your staff nurse at the moment. Therefore, for me, at the moment, you are the most important person in the world. That's what care should be about, and sadly very often it's not. And the emotional stories, so we had people going to lie on railway lines because they couldn't stand the pain. We had people drowning in fecal vomit. Again, we have ways of dealing with these things.
I think the fecal vomit one we should talk about, actually.
Yeah,
That one really got shared. That really is an emotive story, isn't it, this idea that, it's horrible, right? It's horrible, but reality is that there's a lot of different things we can do for that, and they work. And they work quickly. And so the argument is being put that if somebody's in that nasty situation, that people should start going through the legal processes of getting them killed when you'd be only stood on the first step of that legal process before they'd be better again.
Absolutely. I mean, we're talking about gastrointestinal blockages, and we have many very effective treatments for gastrointestinal blockages, completely treatable in the vast majority of circumstances, or at least we can ameliorate. We can give palliative care for that. So we've got the idea of lockdowns leading to isolation, neglect, and death of the most vulnerable. It's quite easy to see someone in the dying situation to feel isolated, especially if they do feel neglected. Or they might think, well, I'm costing my relatives £1,000 a week here, which care costs could easily be or more. Surely I want to leave that to my grandchildren. We have all these emotional triggers that might predispose someone to choose this, for want of a better term, lifestyle option or death style option rather than not. And I just find that whole, we need to take kind of the emotion out of this, really. People shouldn't feel that they, what is an option can very soon become an obligation. I think that's what I'm saying.
And you think, I've, having sort of from a personal perspective, I've been in a place that I think is very common for people when they've got a relative who's dying, which is that of the immediate family who all love this person dearly, there is a conflict between how much intervention people think is appropriate. And obviously,
yes, there is. It should
still be the patient's choice, but inevitably, these things are discussed as a family. And that's something that needs navigating very, very often with relatives, so that people can all get to a place where they are happy with the level of care that's on offer. But there's often a conflict there. Now, if you introduce into that difficult emotional debate the idea that somebody might be killed, what does that do to those family relationships? You said you should kill him or her. That's going to stay forever after that person's died.
Or 10 years later, it was you that killed Mum, not me.
Yeah, absolutely. So when there was one story somebody told, which was really heart-wrenching, of a 17-year-old who died slowly and over, it was a hugely emotional thing, as you can imagine, a 17-year-old dying. And the person was saying how much they felt for the parents and how they wanted to just, take that pain away from them. And you think, well, I don't deny that those parents suffered. Absolutely, that is suffering. You think, well, that kind of suffering in that scenario has the opportunity for some silver linings in terms of their relationship with each other, in terms of their philosophy around death, in terms of, their spirituality. All of those things can be silver linings. If one of them introduces the idea of killing their child, I can only see that tearing them apart. I just, over the however many years it takes, I can't see that having that situation where you need, to be with each other, supporting each other, having that introduced, if they're not completely on the same wavelength, it could only cause harm.
So we've seen in both situations that fundamental principles were breached in the face of death. And I think the analogies are potent. I think they're strong, and I think there's a lot we can learn from them. And I think it's an excellent analogy to help us learn how to move into hopefully a better future from mistakes made in the past. We covered. Is that what we wanted to cover, Claire? I think we've covered the main points.
I think so. There's one more point I'll make just on what you just said there, which
Please.
Was somebody criticised my comparison, saying that in their country, I'm not sure which one it was, that the ordering was different, that they'd had this bill come before lockdowns. The points I'm making are not about one causing the other. It's just about the same methods being used, the same kind of propaganda campaign and mass advertising and rushing through decision making, and it being, because of it's the method. It's the method that's important to spot and notice and realise how harmful it is.
Absolutely. Tell us what you think. Leave your comments. Are we right or are we wrong? We're not telling you what to think. This is just giving information. Take it from there. But do put this into the public radar. We don't want this just to pass on the QT. This is something that we need to talk about because it represents fundamental change. So get this message out there and let's start having this debate, a genuine open public discussion on this. But for now, Claire, as always, fascinating and a pleasure. Thank you very much.
Thank you, John.